So thank you all for tuning in to this week's video. I am revising all the lectures for my core RChem Level 1 ultrasound syllabus. And this is going to be one of the most important ones. And it is about aortic scanning. Now, I would like to give a shout out to all the subscribers to the channel, especially Dr. Hong An from Vietnam and Dr. An Bin from London, Northwest. NHS Healthcare Trust in the UK. If you are new to the channel and would like to learn about point-of-care ultrasound, don't forget to subscribe and ring the bell so you can be notified each time I post content to the channel. Of course, if you like the video, make sure you click the thumbs up button because that helps the channel and lets the YouTube algorithm know that we are POCUS Club. My name is Nicholas Lim. I am an EM and ICU consultant based out of Singapore, and I'm going to teach you about the AAA examination. The aorta is going to fuck you up. Aortic imaging is one of the most important techniques to learn when first picking up point-of-care ultrasound. Oftentimes, trainees and colleagues come to me expressing great difficulty with imaging the aorta with big frowny faces. I'm going to tell you about why we should scan the aorta and how we should scan the aorta. There are a few things that I feel that we should do slightly differently. This was a systematic review in the SAEM in 2013, and this systematic review and meta-analysis evaluated the operating characteristics of emergency departments that performed ultrasonography for abdominal aortic aneurysm. There were 7 studies. The N number was 655, and they enrolled adult patients with symptoms and signs suggestive of a AAA greater than 3 centimeters. The reference standard was a little bit varied. There was CT, MRI, aortography, and radiology performed ultrasound in the mix of all of this. And some of them were even autopsy results. But what they found was that this exam was particularly sensitive, between 97.5 to 100% sensitive, and the specificity ranged from 94.1 to 100. Now, if you have listened to my previous lectures about likelihood ratios, the likelihood ratio for this examination approaches infinity. And by convention, anything more than 10 is a rule-in exam. Anything less than 0.1 is a rule out. So how did we do with the negative likelihood ratio? Over here, 0 to 0.02, which is an excellent test for telling you that this patient's shock is not due to something in their abdomen like a AAA. When you go to a course, you are taught how to scan like this, which is to put the probe at the xiphisternum or the epigastrium, and then work your way downwards. Invariably, what you'll see is this, which is the seagull sign. What you should really be looking at in the first instance, rather than the vessel, is vertebral column, which shows up as this hyperechoic white line with posterior acoustic shadowing, like so. Then, when you go to look further, you will be able to see that the aorta is usually very closely associated. Over here, that's the aorta, and over there, that's the IVC. As you approach the belly button, you will come to the bifurcation, and this is what you will see. That is in the ideal world. That's what you are led to believe. When you go to a POCUS conference or a course, all the models are invariably healthy people, no medical issues. They're probably fasted and they are not in pain. In the real world, reality bites. The patient is never the perfect specimen that you have met and honed your ultrasound skills on at the course. When you put the probe on the patient, invariably, this is what you see. A whole pile of gas, a whole pile of fat, not a whole lot. The reality is that adipose tissue, food, body hair, and bowel gas all get in the way of ultrasound and lead you to get a poor image. If we think about this, we should scan the aorta slightly differently. The aorta runs closer to the anterior abdominal wall at its bifurcation. So we should start scanning from the belly button and then move our way up. Like so. Again, we're looking for the vertebral body, which is this hyperechoic white line with posterior acoustic shadowing. The aorta is very closely associated. Now you see the bifurcation. And notice how close the aorta is now to the anterior abdominal wall. So let's go through some pathology, what you are likely to see. Over here, AAA, so this is an anterior-posterior view. Okay, you can see here again the vertebra. This is the aorta, obviously pathological, with quite a bit of thrombus inside, and we've taken a measurement from the outer wall to the outer wall, and that brings us up to about 7.85. We have also done a longitudinal view of this, and you can see that it's quite a large aneurysm. Over here, you can see we are scrolling through in a video. Okay, large AAA again, some intramural thrombus. Okay, over here another one, similar, quite a lot of intramural thrombus. Be very careful to actually measure this from outside wall to outside wall, as opposed to an inside wall, which you may think is over here, but that's just the start of the thrombus. Over here, here's another one. You can see a lot of clot there. Again, measuring from outer wall to outer wall. The general rule is if this round structure is larger than your vertebra, you're in trouble. It's definitely going to be larger than 3 centimeters. This is that same structure, the same AAA in a longitudinal section. So as you can see, very large amount of wall thrombus there. And important that you measure from here to here. Now, the other thing about AAAs is that the question asked often is not the correct one. People come to me when I scan for AAA and go, is there a dissection, doctor? Is there a dissection? And the answer is not as straightforward as it would appear. If you see a dissection flap like over here, where you can see this is the aorta, and this is a dissection flap. If you look at it in the long axis, you can see that, yes, there's a dissection flap. Yes, you can say that there is a dissection. But if you don't see that, it does not mean that there is no dissection there. If you see a large aneurysm that's more than 3 centimeters, the test is positive. Bring that back and correlate that with your clinical findings, because you are the clinician by the bedside. If the patient has abdominal pain radiating to the back, you may very well be considering the vascular surgeons. If they have a somewhat atypical presentation where they don't really have very much pain and they don't seem very shocked, you may consider getting a CT scan at that point. So that comes to the end of my lecture. Nice and short. Let's recap the main points. Don't be an ass. Master scanning the aorta. Let's do things slightly differently. Hashtag start from the button. Start lower down, start at the bifurcation, and then move your way up. Remember, always look for the vertebra first. Don't look for the vessel at the start. The vessel will be very closely associated with the vertebral body. There is not much variation in this anatomy. And master this. Don't let the aorta fuck you up. If you have any questions, I'm always very happy to take an email. You can scan this. This is on the YouTube. This brings you to the YouTube channel, and you are very welcome to follow me on Twitter. Talk to you soon.